Bismillah ar-Rahman ar-Rahim. Today we are going to talk about hypoglycemia in the general adult population. We know that hypoglycemia might occur in diabetics, in neonates, and in general population. But today our is mainly to talk about hypoglycemia in adult population, non-diabetics. Hypoglycemia by definition in general population is a blood glucose measure below 70 milligram per deciliter accompanied by adrenergic and gastrointestinal manifestation. And all the time we should remember that the figure is not enough alone. We should have both the figure below 70 and symptoms as adrenergic and gastrointestinal manifestation. The clinical picture or the symptoms, the gastrointestinal manifestations comes from as epigastric pain, nausea, and vomiting. The adrenergic ones, which are the main pillars of hypoglycemic manifestations and other, they are such as palpitation, cold calm sweat, tremors, circumoral numbness until the subject reaches coma. So hypoglycemia by definition is a blood glucose below 70 milligram per deciliter accompanied by either a gastrointestinal or adrenergic manifestation. This is a clinical grading for hypoglycemia or bedside grading of hypoglycemia. Grade 1 include mild, in which the patient can help himself. That's to say that when the patients feel the symptoms of hypoglycemia or measures the blood glucose below 70, he can go directly to the kitchen to have a spoon of sugar. He helps himself. This is grade 1. Grade 2, which includes that the patient feels the symptoms of hypoglycemia and the blood glucose is below 70, but he cannot help himself. Someone can get him or help him to have a spoon of sugar. And we mean sugar, but not honey or chocolate, because they need longer times to be transformed to glucose. Grade 3 is a severe state with a cognitive changes, and the patient should go to the hospital to receive glucose infusion and glucagon. And we all know that glucagon is one of the counter-regulatory hormones to insulin. The counter-regulatory hormones are growth hormone, thyroid hormone, epinephrine and norepinephrine, cortisol, and glucagon. So glucagon can be served in the acute stages whenever the patient reaches the hospital or the ambulance. And even if you give the patient glucagon, you should start immediately after a few minutes to give glucose or dextrose, because glucagon is an ultra short-acting hormone. As we said previously, today we are talking about common causes of hypoglycemia in the adults. Hypoglycemia in the adults, classification and differential diagnosis. This hypoglycemia might be either related to a fasting hypoglycemia, that's to say a morning hypoglycemia without eating, and another one called postprandial after eating. Concerning fasting or early morning before eating hypoglycemia, there might be two causes. A secondary cause, such as hypoendocrine changes, and as we said previously, the main player in this endocrine group are the counter-regulatory hormones, either a hypopituitarism or Addison or myxedema, which represent diminished or absence growth hormone, cortisol, and thyroid hormone. The other secondary causes of fasting hypoglycemia, including liver affection or renal affection. And we all know that insulin is degraded primarily in the liver, the first pass in the liver and the second pass in the kidney. Whenever the liver is severely affected, such as acute alcoholism or liver disease, insulin is not going to be degraded and it will be still circulating in the circulation, and it will cause a secondary fasting hypoglycemia. Yes, renal failure. In renal failure, the kidney is incapable of degrading insulin, the second pass, so the insulin will still going there in the circulating and causing hypoglycemia. So the secondary causes of fasting hypoglycemia are hypoendocrine disorders such as hypopituitarism, Addison myxedema, affection of the liver and renal, especially that the liver is the first pass of insulin degradation and renal is the second pass. And by liver, in Western countries we have alcoholism, and in Middle East we have liver failure, and lastly renal failure. Yes, these are the primary causes of fasting hypoglycemia, and these are the crucial and the most important causes. For fasting hypoglycemia, we have two important points to remember, either due to hyperinsulinism or due to non-insulin secreting tumors. And by hyperinsulinism, we mean either an endogenous one, such as pancreatic beta cell tumor, between brackets insulinoma, or either self-administration of insulin or oral hypoglycemic agents, suicidal or factitious. And the other pillar is the non-insulin secreting tumors. So, fasting hypoglycemia, primary causes are either due to increased insulin secretion or factitious insulin secretion, endogenous one, such as pancreatic beta cell tumor, insulinoma, or self-administration of insulin and oral hypoglycemic agents in factitious and the non-insulin secreting tumors. In these tumors, the tumor secretes substance which looks like insulin and exerts its action. It looks like paraneoplastic syndrome. What are the common causes of hypoglycemia in adults? The other pillar, we talked about the fasting hypoglycemia, but now we are going to talk about postprandial hypoglycemia. And postprandial hypoglycemia, it looks that also it has two important pillars. An early hypoglycemia after eating, such as post-gastrectomy or the damping syndrome, or increased vagal tone, which we see in neurotic and anxiety neurosis in girls with hypoglycemia. And we have a late hypoglycemia, or we say postprandial late hypoglycemia with occult diabetes. As we said early, we might have a defect or deficiency or malsecretion of the counter-regulatory hormones. And also, all the time, we should think that there will be a balance between insulin and the other counter-regulatory hormones. And these are the growth hormone, the thyroid hormone, the epinephrine, the cortisol, and glucagon. Whenever there is a deficiency of one of these counter-regulatory hormones, we face or see a hypoglycemia. The other cause is idiopathic. And sometimes we face this cause sometimes when we don't reach a clear diagnosis. One of the most important causes of postprandial hypoglycemia in the adult is the alcohol related, and we are going to talk about it later on. And this is most common in the Western communities. In Egypt and the Middle East area, people do not use alcohol a lot. But in the postprandial or the late hypoglycemic occult diabetes, we have a very important group. The group which is said to be immunopathogenic hypoglycemia. And we never hear the word immunopathogenic hypoglycemia or immuno, we think either about antibodies or B or T lymphocyte. The first one which we should think about in immunopathogenic hypoglycemia is idiopathic anti-insulin antibodies. This occurs when the pancreas secretes insulin, but not in the sequences of amino acids as the normal one. We know that insulin is a 51 amino acid with a disulfide bridge between the alpha and the beta chain, but sometimes the body secretes insulin with different sequences of amino acid. So the body treats them as non-self. And these antibodies will bind to the newly secreted insulin and make a complex. But whenever this insulin releases from this antibody antigen complex, the insulin is released in the circulation with the newly released insulin and causes hypoglycemia. But we should know that the bond between this antibody and insulin goes in three ways. Number one, mild or loose, so that the antibody can be released easily. The second one, intermediate, the insulin released in an intermediate form, and in the severe form, the insulin does not release from the bond. So, in the first part of the immunopathogenic hypoglycemia, we have an idiopathic, and you see idiopathic anti-insulin antibodies. These antibodies bonds or makes a complex with the insulin and releases in times unexpectedly with the insulin secreted from the pancreas and produces hypoglycemia. The other group is, it looks a little bit strange, antibodies to insulin receptors. But here, these antibodies acts as agonists. From the word antibodies to insulin receptor, we expect that these antibodies will be antagonists. But unfortunately, these antibodies goes to the receptor and stimulate them to secrete more insulin. They work as an agonist. This is an antibodies to insulin receptor. Lastly, but not the last, the pentamidine-induced hypoglycemia. Pentamidine is a drug which is used in treating leishmaniasis in South America, and this pentamidine stimulates the release of T and B lymphocytes, and this T and B lymphocytes is capable to stimulate secretion of insulin. That's why they produce hypoglycemia. This is very important, one of the postprandial or reactive hypoglycemia, which occurs in those people, concentrate please a little bit, with gastric carcinoma. And these people goes to the surgeon, and when they go to the surgeon removes the stomach, which acts as a reservoir, and they make an anastomosis between the lower end of the esophagus and the first part of the duodenum. The food will pass directly from the esophagus to the duodenum to the portal circulation, and when it reaches the portal circulation, it goes directly to the pancreas and stimulates insulin secretion before this food reaches the general circulation. So there will be an early hypoglycemia. And also this situation is accompanied by defective counter-regulatory hormones such as growth hormone, cortisol, and glucagon. And this situation is called the damping syndrome or post-gastrectomy or early elementary postprandial hypoglycemia. We said about alcohol, and thank God we don't have a lot of alcohol in Egypt. It's in the Western societies. And this is a postprandial hypoglycemia. And this alcohol-induced hypoglycemia is due to depletion of glycogen in the liver combined with alcohol-mediated inhibition of gluconeogenesis. So we have two elements at the first point. Number one, depletion of hepatic glycogen. Number two, inhibition of gluconeogenesis. And lastly, but not the last, we know that alcohol is followed by many times of gastritis and vomiting. Alcohol-induced hypoglycemia is a situation of postprandial hypoglycemia which occurs in the Western population, and it's either due to depletion of hepatic glycogen due to alcohol or diminished gluconeogenesis. Number two, it's followed by gastritis and vomiting. Factitious hypoglycemia, this is a very important one, and it has an important implementation, especially in medical legal. This is a self-induced hypoglycemia due to self-administration of insulin or oral anti-diabetic agents. Mainly, people use it or do it or reaches factitious hypoglycemia due to either suicidal tendency or by mistake. And this is a terrible situation because we look for a long time for the cause until we reach that these patients have a suicidal tendency, there was a mistake, a family problem. But the mainstay, if they take insulin, we can measure the C-peptide and we find it all the time higher. It has an importance in medical legal. Factitious hypoglycemia is the self-induction of hypoglycemia due to self-administration either of insulin or oral hypoglycemic agents. It has an importance in medical legally, and the clue either we know from the patient or measuring the C-peptide. And as we know that insulin is secreted as a pre-proinsulin, then proinsulin, and the proinsulin is degraded to insulin and C-peptide. We don't measure insulin because if the patient is using insulin, he might face an insulin antibodies. This is a very important question, and we look about it recently in the newer years. Hypoglycemia due to pancreatic beta cell tumor, insulinoma. We can have the title in many ways. Fasting hypoglycemic pancreatic beta cell tumor or insulinoma. But whenever we have the title fasting hypoglycemic tumors, we mean pancreatic and non-insulin secreting tumors. But if we say fasting hypoglycemia due to pancreatic beta cell tumor or insulinoma, we mean the pancreatic one. Thanks to God, 90% of this insulinoma, which produces fasting hypoglycemia, are benign adenoma, and they are single. But if they are multiple, they are malignant. Please remember, we have another endocrine gland. When we have a single adenoma, it's malignant, and when multiple, it's benign. It is the thyroid. So we have to remember it when we are studying. When we have a benign adenoma in the pancreas, it's benign. When we have a multiple adenomas, we have malignancy. Insulinoma also is associated with multiple endocrine neoplasia. The famous 3 Ps: pituitary, parathyroid, pancreatic. Insulinoma is accompanied by multiple endocrine neoplasia. The famous 3 Ps: pituitary, parathyroid, pancreatic. The clinical picture here, due to the prolonged situation, is not acute, as we said earlier. The symptoms here are subacute or chronic neuroglycopenia. Symptoms in insulinoma are subacute or chronic neuroglycopenia because it happens for a long period. The symptoms mainly are called Whipple's triad. Whipple's triad. The symptoms of insulinoma is the Whipple's triad. The characteristics of this Whipple's triad: history of hypoglycemic symptoms, which we said earlier, such as palpitations, circumoral numbness, cold calm sweat. But the mainstay here, that the fasting blood glucose is below 40. Earlier, when we talked about hypoglycemia in the general circulation, we said it's 70. We here say that in insulinoma, the fasting blood glucose is below 40. And immediate improvement after intake of glucose, not honey and not chocolate. So the Whipple triad is the characteristics of hypoglycemia in fasting hypoglycemia or insulinoma, history of hypoglycemic symptoms, a fasting blood glucose below 40, immediate improvement after intake of glucose. These are the symptoms. These symptoms develop early in the morning. When we hear early in the morning, that's to say it looks like fasting. Or after a missing meal, it looks like fasting. Even after exercise, this is between brackets. But symptoms develop early in the morning, it looks like fasting or a missing meal. Not after meal. If it's after meal, this is not insulinoma. The symptoms in insulinoma: blurring of vision, diplopia, seeing the matters too, headache, slurred speech and weakness, personality and mental changes, cognitive ones, coma. But the mainstay or the most important part here is sweating and palpitation may not occur. Please remember, in insulinoma or fasting hypoglycemic pancreatic tumor, sweating and palpitation may not occur. We said earlier that sweating and palpitation are one of the mainstay of adrenergic manifestation. But this sweating and palpitation in insulinoma might not occur due to 2 causes. The first cause is depletion in the counter-regulatory hormones. The prolonged use of the counter-regulatory hormones, such as the growth hormone, the thyroid hormone, the epinephrine, the norepinephrine, and glucagon for a long time will deplete the stores. So number 1 cause of sweating and palpitation may not occur is defective or diminished release of counter-regulatory hormones. The other cause is adaptation. Whenever you have adaptation, you have diminished in the sympathetic drive. So the main causes of sweating and palpitation that may not occur, or we say hypoglycemic unawareness, the main cause is either defect in counter-regulatory hormone secretion or adaptation to hypoglycemia. And we see here that hypoglycemic unawareness is one of the most important mainstay symptoms that may occur in hypoglycemia. Other Other causes of hypoglycemic unawareness than insulinoma, hypoglycemic unawareness, that the patient cannot sense or feel hypoglycemia. Number one, we have insulinoma or fasting hypoglycemic tumors. Number two, the use of non-cardioselective beta blocker. And number three, lastly but not the last, autonomic neuropathy with prolonged duration of type 1 diabetes. Laboratory investigations, we make the most important one, that in the fasting state or during the attack of severe hypoglycemia, we take a blood sample. And when we take this blood sample, we measure the glucose and the insulin. And we find increased insulin secretion and diminished blood glucose below 40. It's called insulin glucose paradox. These are the diagnostic tests, but they are no more used, but they are in the text. Prolonged fasting under hospital supervision, that we keep the patient fasting and we see hypoglycemia, but we should do this in a hospital. That's why, to show that there is excessive or autonomous secretion of insulin without stimulation, because we know that the main stimulation for insulin secretion is either glucose or protein or amino acids. So when you have the patient in the hospital, because not outside, to prevent hypoglycemic crisis to the brain and to the eye. So prolonged fasting under hospital supervision, measuring proinsulin, because proinsulin have an insulin-like effect, and as we said earlier, insulin is secreted as a pre-proinsulin, then degraded to proinsulin, and the proinsulin is degraded to C-peptide and insulin. The last, which we no more used, they have a glucagon or tolbutamide test. Tolbutamide is a sulfonylurea drug, which we call it a primary group, which is no more used nowadays. Before thinking about an operation, we like to localize the beta cell tumor. MRI doesn't show sometimes the microadenoma in the pancreas, but it might show hepatic metastasis. Long ago, there was using a percutaneous transhepatic vein catheter to measure the insulin assay in the head and the body and the tail. The area with increased insulin secretion is the site of the adenoma. And this is very important, because if there is a surgical procedure, it can be done there. Treatment. If we localize the site of the tumor, the very much appealing therapy is surgical, to remove this part. Surgical removal of the part either in the head or body in the tail which contains this adenoma. Diet. And by diet we means frequent complex carbohydrate. Every 2 to 3 hours we give food which contains complex carbohydrates, such as bread, beans, fruits like apple, and we don't give simple monosaccharides such as sugars or sweets, because when we give them, they augment or increase the secretion of insulin therapy. So concerning diet, we use a frequent complex carbohydrate which can be used, and the non-use of the simple monosaccharides. There is 2 other medications, such as the diazoxide and the streptozocin, which destroys the beta cell, which are no more used for the treatment of insulinoma. Octreotide is a very important mainstay drug. Octreotide is a somatostatin analog, and we know that somatostatin has the capability to suppress insulin and glucagon secretion, and also suppress growth hormone secretion, and also produces vasoconstriction of the splanchnic blood vessels. So octreotide, which is a very important point and it goes to the exam frequently, octreotide is a somatostatin analog which is synthesized through recombinant DNA technology. Its main function to suppress growth hormone secretion, suppress insulin and glucagon secretion, and produces vasoconstriction of the splanchnic area. It's used in the treatment of acromegaly, insulinoma, and rupture esophageal varices. But we should remember all the time that this octreotide is expensive and it might induce nausea and vomiting. These are the main line of treatment, either surgical, diet, diazoxide and streptozocine, but please remember octreotide. Octreotide is a somatostatin analog synthesized through recombinant DNA technology. It diminishes secretion of growth hormone, it diminishes secretion of insulin and glucagon, it produces vasoconstriction of the splanchnic blood area. It's used in the treatment of acromegaly, insulinoma, and rupture esophageal varices in variceal bleeding. Sometimes when the questions come about fasting hypoglycemic tumors, we talk about insulinoma and pancreatic and the extra pancreatic ones. And by the extra pancreatic ones, or the paraneoplastic syndromes, these are rare tumors which secretes materials which look like insulin and stimulate insulin secretion, such as retroperitoneal sarcoma, hepatocellular carcinoma, and adrenocortical carcinoma. And unfortunately, the prognosis in these three tumors is very bad. We talked about the post-gastrectomy syndrome, and this needs frequent, simple diets every now. The factitious, again, it's a self-induced hypoglycemia due to self-administration of insulin or oral hypoglycemic agents. It's important in medical legal. We should either measure C-peptide, high level of insulin antibodies, or high immunoreactive insulin. This is important in medical legally, and in the next few years it will gain a much important. This is a self-administration either of insulin or oral hypoglycemic agents. We diagnose them by high immunoreactive insulin, but the main important one is measuring serum C-peptide and high level of insulin antibodies. And thank you very much.